This is the recorded lecture for the reproductive system. Medications that affect the reproductive system include hormones that stimulate puberty, like estrogen and progesterone in females and testosterone in males. They can also replace a hormone deficiency or prevent pregnancy, which includes oral contraceptives, the hormonal patch, ring, and injection. Androgens are hormones produced by ovaries, testes, and the cortex of the adrenal system to develop sex traits. Medications that are used to treat benign prostatic hyperplasia, called BPH, include 5-alpha reductase inhibitors and alpha-1 adrenergic agonists like finasteride, which is on your drug cards for this week. Phosphodiesterase type 5 inhibitors like sildenafil are used to treat erectile dysfunction and BPH. Sildenafil is also one of your drug cards for this week. When we talk about estrogen hormones, we're looking at the prototype conjugated equine estrogens. That's one of your drug cards if you want to pull it out. Estrogens are used for contraceptives. They're used for acne in young females. They're used for menopausal symptoms like hot flashes and mood changes. Estrogens can be used for dysfunctional uterine bleeding and treatment of prostate cancer. The use of estrogens can affect clotting factors, can also increase the risk for estrogen-dependent breast cancer in BRCA1 patients, and can increase the risk for endometrial and ovarian cancers. Oral contraceptives are mainly used to prevent pregnancy. Most are a combination of estrogen and progesterone. The prototype is ethinyl estradiol and drospirenone. Some combination medications also treat fluid retention, which causes many of the uncomfortable manifestations associated with premenstrual syndrome. So sometimes we can prescribe oral contraceptives to treat PMS. Other general uses for oral contraceptives may include decreasing frequency of hormone-reduced migraine headaches, stabilizing the regularity of their menses or period, and reducing risk for disorders such as uterine and ovarian cancers, pelvic inflammatory disease, benign breast disease, and ovarian cysts. So these can be prescribed for a variety of reasons. The estrogen and progesterone in oral contraceptives mimic the properties of natural hormones, except they provide a constant rather than the normal fluctuating level of these hormones in our bodies. As a result, the secretion of follicular stimulating hormone and luteinizing hormone is suppressed, and because FSH causes maturation of an ovum and LH causes the ovum to be released from the ovary, when they are suppressed, ovulation is prevented. The progesterone in oral contraceptives promotes production of thick cervical mucus, which also provides a barrier to the passage of sperm and helps to prevent pregnancy. Oral contraceptives also prevent sufficient thickening of the endometrium, which is the lining of the uterus, so that even if ovulation does occur, the ovum is unable to attach to the uterus because the endometrium is not thick enough. The combination of ethinyl estradiol and drospirenone is effective in decreasing some of the uncomfortable effects of premenstrual syndrome, which include water retention and abdominal bloating and pain. This is very important. The combination oral contraceptives increases a client's risk for thromboembolism, which are blood clots, which may in turn cause a myocardial infarction if you get a clot in your heart, pulmonary emboli if you get a clot in your lungs, or a stroke if you get a clot in your brain. So think estrogen equals emboli. Therefore, we don't give combination oral contraceptives to patients who are at high risk for clots, and those could be patients who smoke, patients who have a history of hypertension, or a history of a previous clot like an MI, a PE, a stroke, or a DVT. So if a patient is taking birth control pills and they start complaining of unilateral leg pain or swelling, think DVT. We also need to make sure we teach these patients not to smoke because that increases their risks for clots. St. John's wort, tetracyclines, penicillins, and cephalosporins can cause birth control pills to become ineffective. So think penicillin pushes the pill, and tetracyclines and cephalosporins cause childcare. That's a way to remember that when patients are on those antibiotics, or that herb, St. John's wort, they have an increased risk of getting pregnant. Note that it is normal to have some spotting and sore breasts in the first few months of taking a birth control pill. Female clients who have the gene mutation called BRCA1 are at an increased risk for developing breast cancer if they take oral contraceptives. So we need to make sure patients who are diagnosed with the BRCA1 gene are not taking combination birth control pills. Hypertension can also be an adverse effect of oral contraceptives. However, when they take low estrogen preparations, that risk is decreased. Oral contraceptives are teratogenic, which means they can cause the fetus harm. So we always have to make sure someone is not pregnant before they start oral contraceptive therapy. Clients taking oral contraceptives also need to use an additional method of contraceptive for the first cycle in which they begin the oral contraceptives. Clients should take the pills at the same time each day according to the contraceptive dosing schedule prescribed. A typical dose schedule consists of 21 days of taking a medication-containing pill followed by 7 days of taking an inactive pill, but be sure to have clients follow the manufacturer's instructions for missed pills. That usually means taking one missed pill with the next pill, 2 pills for 2 consecutive days after 2 missed days, and after 3 missed days, starting a new cycle 7 days later with the use of alternative conception in the interim. Because oral contraceptives can cause clots, we need to instruct those clients who take them to report leg or chest pain, leg edema, sudden changes in vision, severe headache, shortness of breath, which may mean that a serious cardiovascular event is occurring. Clients should stop taking oral contraceptives at least 4 weeks before any surgery that increases the risk of thrombolytic events. Again, we really need to advise clients not to smoke if they take oral contraceptives. Clients should also be monitored for hypertension. Clients are encouraged to receive routine physical examinations every 6 to 12 months while taking oral contraceptives. Emergency contraceptives. For a client who can become pregnant and experiences unprotected intercourse or contraceptive failure, emergency contraceptive therapy is most effective when it begins as soon as possible. The prototype medication for emergency oral contraceptives is levonorgestrel. Levonorgestrel impairs ovulation and luteal function and may prevent fertilization of an egg by thickening the cervical mucus to slow the motility of sperm. A client should take the emergency contraceptive dose within 72 hours of having unprotected intercourse. The medication is most effective when taken early. Administering it with food or administering an antiemetic medication 30 minutes before may decrease the risk of nausea. Adverse effects include abdominal pain, breast pain, changes in menstruation, fatigue, dizziness, headache, and nausea. A client who takes levonorgestrel may be at increased risk for ectopic pregnancy. Oral levonorgestrel should be taken as a single dose at 1.5 milligrams or 2 doses of 0.75 milligrams taken 12 hours apart. If the client vomits within 2 hours of taking it, they need to determine if the dose has to be repeated. Levonorgestrel does not require a provider's prescription and may be purchased over the counter. It is effective up to 72 hours after unprotected intercourse. If emergency contraception fails and a client becomes pregnant, they should notify their provider immediately for manifestations of an ectopic pregnancy, such as sharp cramping or pain on one side of their abdomen. The client should be informed that a small chance of pregnancy still exists after taking emergency contraception. Levonorgestrel should not be taken for routine birth control or prevention of sexually transmitted infections, and it will not terminate an existing pregnancy in which an embryo has already implanted into the uterine wall. The use of carbamazepine, phenytoin, St. John's wort, grapefruit juice, ketoconazole, and cimetidine may decrease the effectiveness of levonorgestrel. So now we're going to switch from contraception to menopause. Menopause typically begins around 45 to 55 years of age when the ovarian follicles, which produce most of a client's estrogen, begin to decline. This decrease in estrogen causes gradual menstrual irregularity and eventually a complete end to menses and fertility. Yay! The loss of estrogen can cause many physical manifestations and body changes, including hot flashes, insomnia, atrophy of the vagina and vulva, bone loss that can cause osteoporosis, and altered metabolism of lipids, which can cause high cholesterol levels. Nothing fun there. There are two types of hormone replacement therapy known as HRT that treat menopause. One type is estrogen therapy alone, and the other is a combination of estrogen and progesterone therapy. Progesterone is included along with estrogen in therapy for clients who still have a uterus to protect them from an increased risk of endometrial cancer of the uterus. Clients who have had a hysterectomy, which is a surgical removal of the uterus, do not need to take progesterone as part of their hormonal replacement therapy. Estrogen therapy in menopausal clients relieves hot flashes, also called vasomotor manifestations, and prevents atrophy of the vulva and vagina, as well as bone loss that can cause osteoporosis. The prototype medication that relieves menopausal manifestations is conjugated equine estrogen, which is one of your drug cards. Other estrogen preparations for HRT include transdermal forms of estradiol. Several intravaginal forms of estrogen are available as well. Estrogen works by binding to estrogen receptors in target tissues, such as the genital organs, the breasts, the hypothalamus, and the pituitary gland, to maintain the functions of reproduction and feminization. HRT substitutes the normally fluctuating amounts of estrogen in the premenopausal client with a smaller but stable amount of estrogen to prevent menopausal manifestations. Nausea is a common adverse effect of taking estrogen, which tends to decrease with continued use. Hypertension can also be an adverse drug reaction. Taking estrogen also causes endometrial hyperplasia, or a buildup of the tissues that line the uterus. This increases a client's risk for endometrial and ovarian cancers. Again, estrogen also increases the risk for thromboembolic disorders, such as thrombophlebitis, pulmonary embolism, stroke, and myocardial infarction. Estrogen increases the amount of clotting factors in the blood, making it more likely for clots to form. The risk for development of thromboembolism increases with the dosage of estrogen a client takes, so for this reason, clients taking any type of estrogen should always take the lowest dose possible for the therapeutic effects desired. Again, the incidence of thromboembolism is higher in clients who smoke and in clients who experience decreased mobility after a surgical procedure. Estrogen replacement therapy is contraindicated for clients who have a history or other risk factor for thromboembolic events, and for clients with suspected or confirmed breast, vaginal, cervical, or endometrial cancer, because it can make it worse. It is also contraindicated in liver disease and in clients with undiagnosed vaginal bleeding. Take precautions in clients with hypertension, gallbladder disease, diabetes mellitus, heart disease, migraine headaches, or kidney dysfunction. Hormone replacement therapy can also be provided by giving estrogen and progesterone. These medications together relieve severe manifestations of menopause, such as hot flashes and vulvar and vaginal atrophy. Use of these medications may also help prevent postmenopausal osteoporosis. The addition of progesterone antagonizes estrogen-influenced tissue growth in the uterine endometrium and thus prevents hyperplasia or a buildup of lining in the uterus. Continued growth can increase the chance for cancer cells to develop, so for a client experiencing menopause, this growth is unnecessary. So progesterone added to estrogen and hormone replacement therapy helps suppress tissue growth in the uterus, decreasing the development of endometrial cancer in the client experiencing menopause and who has a uterus. You already know about progesterone as a contraceptive and as protection from uterine cancer in clients on hormone therapy replacement. Progesterone also treats endometriosis, dysfunctional bleeding of the uterus, and is a palliative treatment for advanced uterine cancer. Testosterone is an androgen and a hormone. The purpose is to develop male sexual traits, maturation of sperm, increase in skeletal muscle, and increase in erythropoietin, which are the hormones that make red blood cells. We can use testosterone for hypogonadism in males or delayed puberty in males. Complications, these are not for females except sometimes in menopause or for postmenopausal breast cancer. In males, these can cause acne, priapism, increased facial hair, and penile enlargement. Can also cause jaundice, so we need to monitor the liver enzymes. Can increase the cholesterol in our blood, so we need to monitor those levels. And we do not give testosterone to patients who have prostate cancer. Androgens can alter effects of oral anticoagulants and insulins, anti-hyperglycemic agents, so monitor PT-INR and blood glucose in patients taking testosterone. 5-alpha reductase inhibitors. The prototype medication for this class of drugs is finasteride, and the purpose is that it decreases usable testosterone, causing a reduction in the prostate size and prostate-specific antigen levels. Complications of taking finasteride, this is one of your drug cards, is decreased libido, decreased ejaculate volume, and gynecomastia, that is breast tissue in male patients. Clients who are pregnant and females of childbearing age should not handle crushed or broken finasteride. Alpha-1 adrenergic antagonists include tamsulosin, otherwise known as Flomax. The purpose of these medications are to decrease mechanical obstruction of the urethra by relaxing smooth muscles of the bladder, neck, and prostate. So it can also lower blood pressure for those who have benign prostatic hyperplasia and hypertension. Because it can cause hypotension, one of the complications is hypotension and other signs and symptoms like dizziness, congestion, sleepiness, faintness, and problems with ejaculation. Contraindications, clients of childbearing age should not handle these medications. Another medication from your drug cards are phosphodiesterase type 5 inhibitors, and the prototype medication is sildenafil, otherwise known as Viagra. The purpose of sildenafil is to augment nitrous oxide release during sexual stimulation, which results in enhanced blood flow and penile erection. This medication is used to treat erectile dysfunction. Complications include sudden death, MI, priapism, and sudden hearing loss. Sildenafil is contraindicated in any clients taking any medication in the nitrate family, like nitroglycerin, because it can cause fatal hypotension. We also use this medication cautiously in clients with cardiovascular disease. Take 30 minutes to 4 hours before sexual activity, depending on dosage.